to talk to a patient about. The information that is here, especially what is how they have laid it out in this chart, is really nice. Keep in mind, this is more what a specialist is going to do. I can tell you that in my diabetes clinic, when I saw a new patient, I usually spent 45 minutes to an hour getting the history. Okay? So it takes a long time to get all of this, but I usually was getting people who had been diagnosed, had been failed all kinds of treatment, so then they send them to us. So that was, so there, I needed to know a lot about what had happened to them. So I think this kind of information can be certainly broken up and talked about over several visits. But it will all help you in terms of, too short. So in terms of the American Diabetes Association, what they are moving to and what they really recommend now is much more emphasis on comorbidities. What else is going on with the person? Okay, that's important. I see that. So I'm just kind of telling you their gist. But again, they are endocrinologists, so people are going to be sending them patients that they have known, done. So that's a little bit different approach. So we're going to look at more from a primary care. And I'm going to sit, because that's the way I would talk to you if I was a provider. Okay, so usually one of the first things I want to do when I see somebody who has diabetes is I want to know their story. If they know that I understand their story, they're much more likely to listen to me. I want a relationship with them, because usually when you're dealing with somebody with diabetes, it's long term. Diabetes also takes over your life. So everything you used to take for granted, Audrey's eating a cookie. You're doing So if you have diabetes, you have to think about it. You have to think about when you get up, what you put in your mouth, when you, if you're going to be active, if you're going to go drive, if you're going to work out. All of those things have to be thought about. If you have type 1, you have to think about them a lot. If you have a kid, you have to think about everything. So it really is a disease that can be very possessive and obsessing for the patient. So our goal with diabetes is to move that person so that they are a person with diabetes. They are not a diabetic that happens to be a human. Very different approach, right? So we're not going to treat them like they're a disease that has come to see us that happens to be human. They are a person that has this disease, and what we want them to see is you are a person, you have this disease, and we want you to live like a person that manages a disease. Very different. We don't want it managing them. Diabetes was one of the first diseases that really operated on patient-centered care. After the Diabetes Control and Complication Trial, which came out in '93, they figured it out. You got to put the person in the middle. The person is at the center of care. It's not you, it's not the physician, it is the person, because they are the ones that have to go home and manage the disease every day. They're not going to take you home, and they're not going to take all the specialists home that they see, but they have to be the ones who manage. So they are the most important person in this process. So what I want to know is I want to know your story. I want to understand you. And then the more I understand, the more I can help bring you into things that are going to be best, that you can use to help best manage at home or wherever you happen to be. So some of the things to ask people about is onset. I always like to know what happened when you were diagnosed. I hear some of the most wild stories. So I want to know, were you symptomatic? Did something happen to you? Did they just find it? So sometimes they'll say, no, they just found it, but often it was something major had happened. A stressor, an illness, or my mother got sick and then I realized I had the same things. Just all kinds of circumstances. So what happened, what were the symptoms, and then I want to know, well, what did they do? Or how did you feel about that? Usually I'll ask them, okay, well, how'd that feel? And then I want to know what they did, because sometimes what was done to them helps me understand what they thought was going on. So you were hospitalized, and because you're coming to me now and you're on no medicines, okay? Or you're coming to me and you're on oral, but you're telling me that while you were in the hospital, you had to have IVs and all this stuff, you didn't know where you were for a couple of days, and when you got out you were on insulin. It's like, now how did you get to where you are now? So I like to connect the dots. Here's an amazing story. Had a young man come in. He was probably in his late 30s, early 40s, and he showed up because he was came to one of the doctors, and he was told him he was diabetic and on insulin and had just gotten insurance restored. So his blood sugar was like, I don't know, his A1C was around 10%. So they sent him over to us, and I started talking to him just about his story, and he said, well, about 5 years ago, I got really sick. I went into the hospital. They told me I had diabetes. They started me on insulin, and when I got out, I had an appointment with a diabetes doctor. I showed up at the office where I thought I was supposed to be, and they told me that they didn't have any appointment for me and didn't know where I was supposed to be. And I said, well, what'd you do then? He said, well, I didn't know where to go, so my wife and I went on the internet and we researched all how to dose insulin, and for 5 years he did it on his own.
Wow.
Because you can buy NPH and regular over the counter without a prescription, because they were approved before the laws came into being. So, see, just that one thing, just that clerk sitting there going, I don't know where you're supposed to be, and not doing anything to help them and facilitate, well, you're probably not supposed to be here, you're supposed to be over in this residence clinic. Never connecting those dots, dropped through but they had the sense. I was just amazed that they had the wherewithal to go on, and you know what? They did pretty well. Pretty well. Given that they knew nothing beyond that, except that they could figure it out on their own. I was just stunned. So that's one story. So wanting to know treatments, have you been hospitalized? Hospitalizations tell me how not fragile is not the word, but your ups and downs. If you're having to frequently be hospitalized, there is something wrong. Something, either you can't afford your medicines, you're having frequent something. Maybe you're a type 1 and no one's told you that. But there is something wrong, or something driving you into the hospital. So that goes to maybe severity. If they've had a lot of DKA, that's bad. It's very hard on the body. Sometimes people use it as a way to manipulate. Sometimes it's just flat because they don't have the drugs. So in the population I dealt with at Family Medicine, that was pretty common. People just ran out of medicine. Insulin's very expensive. A bottle of Lantus is about $160 to $200. It doesn't even last a month. And for some people, run out of money and they can't afford it. So find out their story. When did it start? What type are you probably dealing with? How's it been treated? And to what severity? More hospitalizations, more likely complications. What is their family history? So who has what? Or does anybody have it? So some people will have no family history. Sometimes it's helpful to me to know, well, how was your family members treated? So were they put on insulin? Because often patients in the past, if their mother or father was put on insulin, they often were done at the end. So you will hear a lot of older people say, I don't want to go on insulin. Well, why not? Well, because when they put my mother on insulin, she died. If I've heard it once, I've heard it 1,000 times. So what that goes to is a time where we didn't have that, either there was a delay in diagnosis, we didn't have the information we have now, maybe you're dealing with a doctor that wasn't very aggressive, all kinds of reasons, but very frequently people will tell you, so-and-so died, my uncle died, as soon as they put him on insulin, they died. So they couple those things together. So a lot of insulin with type 2s is unraveling all the fears or worries people have. When people have to go on insulin, it's real, okay? If you're on a pill, well, it's not bad. If I take 5 pills for diabetes, isn't that bad? But when I have to go on insulin, now it's real. And that is a huge thing for a lot of people. Oh my gosh, I really do have diabetes. Or I really have something serious. Now I have to take insulin. But it also kind of goes to, I like to know if family members have diabetes, what complications do you have? If you've got several aunts and uncles who had to go on dialysis, it usually speaks to genetically you may be geared that way. Tends to kind of go with genetics. So I'd like to know that. I'd like to know their what their attitudes are towards treatment. I'd like to know, well, what do you think about having diabetes? I told you in the African American population, it's like, that's everybody has that. So anyway, complications are sometimes an insight as to what they may be also at risk for. So eating patterns. Now, you may not have a lot of time to deal with this, but you can garner a few things. Because mostly when people find out they have diabetes, the first thing they want to know is, what can I eat? It'll be the next thing out of their mouth. What do I eat? What do I do differently? So eating patterns, nutritional status, especially if they're a type 1 and they have been losing weight. Children, we want to restore that health. We want to keep kids on the growth curve. We want them to develop. We want their brains to keep developing. We don't want to interfere with that. What their weight history is. Here's how I approach weight history. I usually ask people, okay, are you happy with your weight? When I start dealing with African American women, I realize very fast is they don't look at it like Caucasian women. They're much happier with being heavier. They would often tell me, oh honey, I'm past that time. I'm past that time. I don't need to be that weight anymore. So a lot of them, 200 pounds was, for them, 200, 250 was pretty normal and pretty comfortable, and they didn't want to be any less than that. So what is normal for them? What do they think? Trying to get them to lose weight sometimes was difficult out of that. I had one lady one time, she lost down to 170, and she goes, oh, I'm just too skinny. And so it's just different. It's their culture. That's the way they look at it. So I want to know, are you happy with your weight? Do you want to lose weight? Are you doing anything actively to lose weight? What would you like to weigh? So often they'd say, well, they'll give me a weight like, and I never knew if it was because that's what you thought I wanted you to weigh or what, but so you're 250, I want to weigh 110, okay? So usually what I would say is, when did you last weigh that? And they would tell me when I was in high school. So, like, okay, I would never say anything. Usually what I would tell them is, what have you weighed in the last 10 years? What's your lowest weight? Because to me that was more realistic than what you weighed when you were in high school. So that usually, and then I would start to negotiate weights. The thing with diabetes, as I've told you, is that small steps mean big payoffs. So we'll see this with prediabetes, is that 5 to 7% weight loss has huge impact on insulin sensitivity. Their insulin sensitivity will go up and their blood sugars will improve. So if you're 200 pounds and I'm telling you I need you to lose about 10 to 15 pounds, that sounds more reasonable than me saying, I really want you to lose 100 pounds. What are you going to do? Okay, so that's usually what I would do, is I negotiate a reasonable weight. Okay, if you want to try to get down, lose 100 pounds, I'm not going to get your way, but what I would like you to do is negotiate down to, when I see you next, however long that is, let's look for a 10-pound weight loss. And then I talk to them a lot about how would you make that work? What does that look like? So finding out how often they eat, what times they eat, do they eat at home, do they eat out, that makes a big difference. If you eat at home, you have a lot of control over your food, right? Your calories. If you eat out, you don't. You don't know what they do, what they make it. They're making it taste good, it's got calories in it. More than we would probably expect. How often they eat. If they eat once a day and you're looking at putting them on insulin 4 times a day, that will not work. You have to match things to what they do. Usually the first thing people ask me is, what can I eat? Or give me a menu. Just tell me what to eat. I never did it. I never fell into that trap because it doesn't work. You can tell people, but they will revert to form. So I usually worked with, what do you like to eat? Let's start there. What do you want to eat? And then we would work on that. Now, if they were eating bad stuff all the time, we would try to work it to where we focus on healthy stuff, and then what do you absolutely have to have? What will derail you if you don't have it? Had a lady who, she really liked candy bars. She loved Milky Way candy bars. So she got to where she would carry one in her purse, and she said, I never eat it, but I know it's there, and I know I could have it anytime I want it. And she never touched it. But that was her thing. So I never talk about bad foods or good foods. I never label foods, only sodas. I cannot control anybody's blood sugar if they drink sodas. I just can't. If you drink regular sodas and you're taking in liquid sugar all the time, there is no way to cover your blood sugar. There just isn't. It's the only food I will tell people you need to quit. And I've had people never come back and see me again. Rare, but that's the only food I'll ever tell people just to stop. And what I will do is I'll negotiate with them. If you, for 3 days, will just stop doing that and see what your blood sugars are, then you tell me what you think. Most of the time they'll make they'll amend it. Taylor, you have anything to throw in there?
No, I think that's good. A lot of people would ask me for like a specific menu too, and I wouldn't do that either. So, yeah. But
Work with what they'll do. Even if it's bad, you can move them along. So time of eating will help you when you go to try to figure out what kind of drug to use or to give them options. Because this is the way you like to do things, here are the options that I would recommend. And I would lay out the good and the bad, the pros and the cons with them. Here's what we can expect with this, here's what we can expect with that. And I know you're sitting there thinking, in 7 minutes, there's no way I can do it. But I tell you what, you can get fast because you'll figure out where's the highest yield questions. So this is just kind of everything. Food's insecurity, depending on where you work. That's why it's good wherever you move to is figure out where do your patients live. Over in the family medicine, in that area we live, that is a food desert. There are very few places where they can go to get food, and what they can get is not very fresh. So it really is a desert. I had to be aware of what they could get their hands on. You also want to know about food insecurity. So go back and look at that. I gave you a handout, and I did a PowerPoint on food insecurity. How often are people going without food? People who don't have who have very fixed low incomes usually will have a lot of food at the beginning of the month, and they will have very little food at the end of the month. So their blood sugars will be high in the beginning of the month, and they can be very high or very low at the end of the month, because they either then go to very cheap carbohydrates or they run out of food. Most of our patients ran out of food at about day 20 or 21. So if we were going to have profound lows, they were usually then. I remember a woman calling me and saying, my blood sugar is low, what do I do? And I'm like, okay, what do you have in your house? I don't have anything. I'm like, well, go to your refrigerator, open it up, and tell me what you have. And she had nothing. She did have some crackers, so we did have a saving grace. But I mean, if they have, we would run into problems where They're on a fixed income, they've got fixed food. So most of these people live off about $150 of groceries a month. Now you think about that. $150 a month. And they were pretty good. About 2 people eating off that for a month. Okay. So then your kids come over and they dump your grandkids on you for several days. And they eat all your food. So understanding those circumstances will help you a lot in terms of devising. So we had great networks in terms of how to plug people into food pantries and help, and how to get food stamps and all kinds of things. And also we had a great dietitian who made up a grocery list and said, here's what you can eat healthy for $150 a month here. She used all kinds of the food markets in the summer, and she was really good at it. So we would give that out to folks. Do they have transportation to get to the grocery store? Remember the patient I told you that they were doing really well, diabetic, lost her ride, had to go to the 7-Eleven, and her her A1Cs went from 7 to 11%. Okay, so can they get to the grocery store? Alternate shifts. These are the nightmare. Is people who work at nights, or swing shifts are the worst. They work a week of days, a week of evenings, and a week of nights. It's a nightmare. But what I would do with those folks is, at least if they were night shift workers, to me is when does your day start? I just work with what's their paradigm. When does your day start? When do you eat breakfast? When do you eat supper? When do you eat lunch? Lunch for maybe 2 o'clock in the morning. Okay, I can work with that if you're pretty set. Now when they revert to the daytime on their days off, that was hard. But you just have to work with what they are. So what this goes to is know your patients. Because if you prescribe something that is not going to work, guess what? They won't do it. They won't do it. So knowing is better. So getting kind of down the things that are most likely, like in my population, I never asked them about eating out because it was rarely going to happen. If they ate out, it was at the church social, and it was the potlucks, and then that was a whole nother story. Assess their nutritional status, general appearance. Do they look like they're malnourished? People can be very big and be very malnourished. You cannot do diabetes unless you have a dietitian. You just can't. It is impossible. It is a disease that is mostly worsened by what we eat. And blood sugar control is mostly what people eat. So you've got to have a good dietitian. Know your dietitians and know people you can refer them to. Serum proteins, albumin, pre-albumin, transferrin. Using the things that will assess nutritional status may be helpful. These are things a dietitian can do for you in measuring fat stores and nutritional status. Weight history, I've kind of gone over that. Sleep behaviors. Okay, so now more and more we know that sleep influences our weight and puts you at risk for diabetes, right? So knowing their sleep habits. Are they getting enough sleep? Are they doing weird hours? Family medicine, I'm telling you, most of the patients I dealt with were up all night and slept in the day. So that brings its own kinds of problems. Physical activity habits. Activity versus exercise. Exercise what makes you fit. It makes your heart fit. Activity does not make you fit. It helps you burn calories, and it's good to be active, but it doesn't make you fit. So when I ask people about what do you do for exercise, usually I would get the activity part, and I wouldn't get the fitness part. So ask them about exercise. Type, frequency, duration, intensity, if you can get a sense of that. Time spent being sedentary, working at a computer, watching TV, playing video games. Get a sense of that, because that can be your thing that you negotiate with them. Because eventually, if they're interested enough, they'll get to the point where they're like, what can I do? What can I do? I don't want to go on insulin, so what can I do? Okay, well, you've told me you like to go home at night and lay on the couch for 3 hours and then snack and then get up and go to bed. So it gives me those negotiating points. Where could we make a difference that will pay off for them? Nutrition education. Have they ever had formal education? In the handout that I gave you on lifestyle, one of the first things it talks about was diabetes self-management education. Okay? That is standardized. It is a national curriculum. Places who teach it have to be accredited. So we ran one at Family Medicine. That you see that CD behind my name. I'm a certified diabetes educator. So I have to take a national exam. I have to, we designed a program that met national standards. You have to be accredited. They come and you have to be reapproved every so often. In order to bill for those services, you have to meet those criteria. So refer people, find out who does diabetes education. If they can't afford it, there are lots of places that give it for free. And that might be a little bit harder to find out, but a lot of the wives will do it. Different church groups do it. In the African American population, they are very good about doing classes in their churches. So lots of different people will have different ways to access it. But find out, have they ever had a dietitian? Now, a lot of people early on will like, yeah, I want to know what I can eat. But a lot of people are going to be reluctant. They don't want somebody to tell them what they can do, what they can and can't eat. As if you can make them, you can't make them do anything, but they don't want to hear that that isn't what they should be doing. What is their behavioral support? Know what's going on in the home. Okay? If the home is really disruptive, diabetes never does well in chaos. It can. It will not work. If you have a chaotic life, your diabetes will be awful, your diabetes control. So I had a patient who was blind, lived with her sister. Her sister got into all kinds of trouble and brought people into the house all hours of the night and day who stole her, ate her food, stole her money, took her drugs, and sold them. And they were up all hours of the night, slept during the day, and her A1C was 14%. And it took the community health care worker and I working with her for probably 2 years. I finally just flat said, there's nothing I can do. The chaos in your house is so bad that there's nothing I can do. There's even an inventory, a chaos inventory that you can give people to get a sense. Eventually we got her moved into a more stable place, worked with her to get her into rehab. We worked with her with the folks who work with people with the blind. We got her to where she could use a cane. She became independent. She went to school. She became a masseuse. Do you know how good, blind masseuses are really good. I told you in China all the masseuses are blind. Because that's a job they can do. So the state funnels them into it. So anyway, she over time became a success story. Knowing their support, spousal support, family support, eventually, I may not get that in the beginning, but eventually as things unfold, you start to get a sense that my husband, the Latino culture, I found this to be a big problem. The wife is the center and she does everything. And she will sacrifice a lot that for herself, that for the family, and to her own detriment. Sometimes husbands or spouses do not want their spouse to become skinny because then they might leave you, they might do other things, it's threatening. So there's lots of reasons why people don't make changes, and so sometimes helping to understand that will help. If you smoke a lot of marijuana, it's going to be very hard to control your blood sugar because, number one, you snack all the time. You also, I'm just thinking about this one kid I had, 25 years old, bright kid, type 1, but he had a very stressful family job, and he would go home every night and smoke 4 joints. I said, where's the best stuff? And he goes, California. No, Colorado. That's where he got it. Every night he did it. So for a while, well, after he crashed his car in the second time into a pole, I said, you gotta give up the marijuana and you gotta pay attention to your blood sugars. So he did, but his anxiety went too high and he couldn't do it. But under the influence of marijuana and a low blood sugar, which he couldn't recognize, he wrecked his car multiple times. So anyway, talking to him about other, recreational drugs will be helpful. Okay, medical history. So here are the comorbid diseases. You may have people coming to you in a family medicine. You want to know what are your other diseases because these are frequently in middle-aged, already established. Okay. Their diabetes, if it's not well controlled, will make them worse. Their quality of life will go down faster with these comorbidities. So especially looking at cardiovascular, you really want to address their cardiovascular status. If they don't have known heart disease, then you want to get ahead of the ball. And if they already have it, then you want to get as much under control as you can. So blood pressure. We're going to see that with complications, blood pressure is probably as strong a factor in the development of complications as their blood sugar is. So hypertension is hard on the kidneys, it's hard on your eyeballs, it's hard on the heart. You put diabetes with it and you've got the formula for stroke and heart attacks. Chronic renal insufficiency. So the diabetes is very hard on the kidneys. Number one cause of people being on dialysis is diabetes and hypertension. So knowing about the history of gestational diabetes, we talked about that because that puts them at high risk. History of PCOS, those women are very high risk for diabetes and cardiovascular disease. Fatty liver disease. A lot of the patients that you're going to see are going to also have NAFLD. And then the worst is them progressing to NASH. Depression, high incidence in people with diabetes. Probably more than 50%, 60, 70%. It ought to be something you screen for on a regular basis. It also interferes with their ability for self-care. So if you're depressed, then you don't want to check your blood sugar. You don't want to take your medicine. So it goes a lot to their ability to keep up. Dental disease. Dental disease is one of those that just becomes a vicious cycle. If your blood sugars are high, you are more likely to have gum disease and develop abscesses. The more you have gum disease and abscesses, the higher your blood sugar goes. So I learned this lesson, if you've got somebody who you've done everything you can think of to get their blood sugars under control and you're still having problems, make them open their mouth because they're probably have got gum disease or abscesses or something in there. So bad teeth will go a long way to causing problems with their diabetes control. Tobacco use, alcohol consumption, substance abuse. So if they're smoking, you want them to stop. You always want to be talking to them about that. So motivations to stop. Has Dr. Bird ever told you about Dr. Drew that we worked with in the VA? That's wild. So he was you'll have to have Dr. Britton do his he can just do a perfect mimic of his voice. But with these veterans, so the majority of our veterans smoked. We were dealing mostly with World War II and Korean, a few Gulf War, but mostly World War II and Gulf. So if they came in and they had diabetes and they smoked, he had pictures of gangrenous penises all over the wall. You don't stop, this happened to you. That was his motivation. You got him, Dr. Britton, I'll have him tell you. Oh my God. That was the way he motivated.
Probably got some layers.
Okay, alcohol consumption. So what have you learned off of those handouts that I gave you about alcohol? Should we tell all diabetics don't drink? No. So what can we tell them?
See how much they drink and what they're drinking.
Amount? And so can we recommend that if they're going to drink, they drink what we usually advise people to standard? Yes. So the big things to think about with alcohol is that if you drink too much, what is your awareness of a low blood sugar? It goes down. So the ability to have good judgment. So a lot of when you're working with teenagers and college kids, you really want to drive that home. About just the ability to recognize in yourself when you need help and to be able to administer it. The other is that alcohol can interfere with the ability of the liver to respond to a low. So the ability of epinephrine to work on the liver and release sugar can be blunted. So having those conversations with people who maybe are drinking too much is warranted. Metformin is a problem in that too much alcohol can precipitate a very serious and fatal adverse reaction with metformin. So that would be one of the drugs where there would be an interaction between that and the drug, and we'll talk about that. Finding out if they have macrovascular or microvascular complications. Okay, so do they already have eye disease, kidney disease, neuropathy, foot problems, autonomic problems, sexual dysfunction, gastroparesis? Any nerve in the body can be affected, any of them. So the big nerve that goes to the gut, the vagus nerve, can be impaired. And if that's impaired, then your gut doesn't move very well. So they're very prone to developing gastroparesis. Did you all talk about gastroparesis in the gut, in GI? Okay, so these people can get that. So just think about what kind of havoc that wreaks. You eat, and the food stays in your gut, in your stomach, and you give yourself insulin. What's going to happen? You're going to get low because the food's in the stomach. It's not in the intestines where it gets absorbed. So now there's insulin driving your sugar down and nothing to work on. So people with gastroparesis really are, they're tricky. You can often get the gut to respond. You get the blood sugars down, often some of that nerve function will come back and they will develop more normal gut and bowel habits. You want to know when they're, if you're dealing with a poor population or a very old population, they may have no ability to get to the dentist. So that can be a problem from what we've already talked about. When did they last have their eye exam? Type 2s, if newly diagnosed type 2s, you're going to send them for an eye exam right away because they can already have the complications developing. Macrovascular, so coronary artery disease, cerebral vascular disease, peripheral artery disease. So we want to prevent those. So with coronary artery disease, you want to figure out what's their risk. Hypertension, lipids, right? Are they on an aspirin if they've already had a heart attack or angina? Lower that risk. With microvascular, we can prevent or delay with getting their blood sugar under better control. With macrovascular, we cannot do it solely with blood sugar. With macrovascular, it takes all those components. Blood pressure, lipids, antiplatelet, blood sugar. Remember, their thresholds are different. Immunization, so making sure people have had their the immunizations according to schedule. The big ones we're going to want with the people, the adults, is we want them to get a flu vaccine every year. They're at high risk for the respiratory complications of the flu. You also want them to make sure they get that pneumococcal. And the other one, you can put Prevnar down there as well. And we'd like them to have that hepatitis B. The other thing you'd want to screen them for if they are, especially if they're baby boomer age, is Hep C. Remember, two times the risk for diabetes in those over 40 who have Hep C. Okay, medication history. Well, what do they take? Ask them to bring their medications with them. So you want to look at what are they taking that lowers their blood sugar? Are they using a monitor? If they're using a meter already, you can get software and download that data for a lot of the meters. And it'll graph it all out for you. You can see where their blood sugars have been. If they're coming in and you know they already have diabetes, ask them to bring their meter and their logbook so you can see what they're doing. Find out if they have hypoglycemic, how often are they having hypoglycemia? How often is their blood sugar getting too low? If they're having frequent lows, you need to do something right away because that can kill them or put them at great harm. You want to know how satisfied are you? They've done surveys of people who have diabetes about how satisfied are you with your regimen, and most people aren't very satisfied. Because a lot of people don't take the time to try to match what the treatment to how they live their lifestyle. They get prescribed something that has nothing to do with how they live. So the more you match up what they live and what you ask them to do, the more likely they'll stay with it. About 30% of people will admit that they don't take their insulin like they're supposed to. But I'm telling you, it's about 100%. Most people on insulin do not take it the way you would prescribe it. Now, people who use pumps may be a little different. But a lot of people are going to omit, especially type 2s will omit. So we talked about, does it fit their lifestyle? Blood pressure lowering meds, well, how well is it working? Side effects, always ask about adherence, side effects, barriers. Lipid levels, same thing. Contraceptive use in women. If you're dealing with women in their reproductive years, you want to know what their plans are for a pregnancy. The higher your A1C is, the more likely you are to have a child with a congenital anomaly. Above 9%, A1C 9%, it is very unlikely that the pregnancy will be viable. So you've got to have good glycemic control before conception. So usually we want their A1Cs to be below 7%, maybe close to 6% as we can give it. Now here is one of those times where you've got to have good relationships with your patients. Because if they want to have a baby and they feel like you are going to tell them they shouldn't, they're not going to tell you. But emphasizing from the time that they are in their teenagers. Okay, someday you're going to want a baby, and we want you to have the best baby and the best pregnancy you can have. In order to do that, you've got to have really good blood sugar control. I know you can do it. So when you're getting close to that time, several months ahead, we need to start planning. So the average congenital anomaly in the population is about 2%. With diabetes, regardless of control, it's 4% at the lowest. And it goes up. The higher the A1C is at the time of conception, the more likely they are to have congenital anomalies and fatal congenital anomalies, like the anencephaly. So driving that home, if women are having frequent miscarriages, I would see a few of them in the diabetes clinic, can't carry a pregnancy to term, it was usually because of A1Cs. If it's 10 or 11%, I'm just telling you, they won't have a normal, they won't even have a pregnancy. Okay? So glycemic control makes a big difference. We'll talk about this more next month with gestational diabetes. So conception plans, good conception until they're ready to plan and conceive. Find out what their complementary and alternate medicine. What are they using? What do they tramp around the fields and pick up and burn and brew? The more you live out in the country, the more they have these, folk medicines that they may use. What herbal products are they using? Review previous treatment regimens. So one of the number one reason, or not number one, but a high reason for non-adherence in diabetes is the fact that people keep putting them back on drugs that they didn't like or had adverse effects to. So I always ask them, you were on metformin in the past, what happened? Okay, would you ever take it again? Nope, well, okay, write that one off. I'll put it in a tickler file. If I get desperate, I'll come back and talk to you about it again. So financial, can you afford the medicines? Can you afford the co-pays? These folks will often be on multiple medicines. They have to buy strips. They've got to buy other testing supplies. It's expensive. If you're on a meter, you got to buy tubing. Tubing alone will cost you about $150 plus a month. So it can be quite expensive to be a diabetic. How organized are they? If you are disorganized, it is hard to be a diabetic because there's lots of repetitive things that you have to do. Screening. Okay, some things to screen for. Screen for depression. Remember your PHQ-9? Use it. Use it on a periodic basis. High risk for depression. Dr. Britton's going to lead you through a workshop on coping with chronic illnesses. Anybody who has a chronic illness has difficulty coping at times. But there's ways we can teach people to do that. So he'll talk to you about that. There's all kinds of tests out there, attitude tests. So one of them is Eat 26. So it talks about food, people's orientations to food. There's one for general anxiety disorder. I really like the paid questionnaire. I can put it up and post it for you. It looks at a lot of different areas in diabetes, and you start to get a sense of where do you feel like you're doing well and where do you feel like you're struggling and having trouble. Screen for psychosocial problems. The number one thing that will get in the way of you getting them to do what is best for them is psychosocial. You lose your home. Your adult son that lives with you is probably got a mental disease, and one morning you wake up and he's taken a ball bat and he's knocked out every window in your lower floor. Or he knocked out all the windows in your truck. Or he ran your truck and ditched it somewhere. Or your nephew who's been living with you stole all your medicine and sold it. They stole all your supplies and sold it. I mean, it's just number, things. And you don't have to be poor for these things to happen. Crazy things happen to people no matter how much money or resources they have. So finding out, I've got a child that is, has severe disabilities that I'm taking care of. I have a family. I've got a mother and a child that are both in great need, and I'm in the middle. So finding out those things are huge. They are the biggest barriers to getting to taking care of diabetes well. So much so that we lived in. Our family medicine we dealt with a very low resource group. So eventually we hired a community health care coordinator. So she was somebody in the community, knew the community, but had great connections. So she was huge. So we had a man that came in, we'd seen him for a long time, and found out that his water heater went out. So can't cook, can't bathe, can't wash the dishes. So we put her on figuring out how do you get a water heater, and got it installed. She was the one that worked with the blind patient that I had, got her into rehab, got her into visual services. Finally, we got her into a housing that made sense for her. So you become mostly social worker when you're working with people that have chronic diseases, because so much of it gets in the way. And we were lucky at family medicine, we did have a social worker, and so that went a long way to helping us meet the needs of the patients. Let's see, affordability of medicine, supplies, support we talked about. Another screen is for sleep apnea. So anybody who is really obese and has a large middle, they probably have sleep apnea. So there is a questionnaire called the Berlin questionnaire that you can give while they're out in the waiting room. It asks things like, does your partner complain about you snoring at night? Do you fall asleep in the middle of the day? So it's about a 9-question. Getting those people evaluated and getting them treated is huge. Addressing sleep apnea will lower their blood pressure, helps with their blood sugar control as well. Diabetes education, we've talked about. It really does teach the patient how to self-manage. If ever a disease took a village, it is diabetes. You need numerous people to help support. You cannot do it yourself as a provider. You just can't do it. You got to figure out who else, who has resources, and who can I refer to. Literacy and numeracy, depending on, you can be in a very affluent area and still need these. Can your patients read and understand the directions you are giving them? Can they do numbers? Most people can't do fractions, and yet you're asking them to calculate the carbohydrate content of their food and dose their insulin accordingly. It's scary what people do. Ability to self-manage or be a caregiver for a person with diabetes. So sometimes that comes into play as well if you're dealing with family groups. Let's see. Physical exam. So some things to cover is you got to do eyes. You've got thyroid, especially type 1s, they have a high incidence of also having thyroid disease. Number one. In one autoimmune disease, they have multiple. It's rare that people have one autoimmune disease. Skin exam. The skin, there's lots of skin changes that go with diabetes. We'll talk about that in derm. Doing a comprehensive foot exam, we're going to talk about that. Always have people take off their shoes. Always have your nurse always tell them to take off your shoes. I would just tell my patients, anytime you go see a provider, take your shoes off. The schizophrenics were the best. They always took their shoes off. But because a provider can't ignore bare feet. I don't know what it is about it, but you just can't go without saying, okay, you got your shoes off, is there a problem? Inspecting them and assessing vascular response, their reflexes. We will do that next week. Laboratory. So you're going to do A1C, fasting lipid profile. You're going to look for albumin in their urine because that's going to tell you how well their kidneys are working. Serum creatinine, estimate their glomerular filtration rate. And a TSH for those with type 1. Basic standard. Who do you refer to? If they haven't had an eye exam or they're newly diagnosed type 1, the day you see them, you're going to refer them to the eye people. Get them in to see a registered dietitian who does medical nutrition therapy. Not all dietitians do it, but the majority of them are going to be able to do that. Get them into a diabetes education. You need to sell these things. You have to sell them. This is why I need you to go. If you just write the referral and somebody calls them and says, your doctor referred you for diabetes education, they're going to go, I don't need that. Let's see. Family planning, if you've got women of reproductive age, maybe something you want to do. Dentist, if they haven't seen the dentist. And a mental health professional, if they're really struggling, if they've got mental problems that are interfering with their ability for self-care, then those are your basic referrals. Quality of care measures, those measures at the end, guess what? Everybody will be looking at you. Everybody will look at your practice. Everybody in the government will judge how well you're doing. And if you're not, they'll send you letters. Your patient is not an ACE member. Have you considered that? You want to crumble up and go, yes, I've considered it. Your patients, only 60% of your patients have an A1C in the last year. So diabetes is high on the list for everyone, the government, and those who pay you looking at it. So, and these are the things, these are standards for every one of these, and they will judge you against it. You will get a report card. Questions? So it's a lot. So I could cover most of that in about an hour with the patient. But you can see where you would break it up. And you'll learn high yield. High yield questions do the best. Okay, let's take a break. Let's do about 15 minutes. Let's come back at about 10 after 3, and then we'll start coming back. And I'll stand up.